A dental bridge is a fixed replacement for missing teeth, anchored to adjacent teeth or implant. In the U.S., tooth loss is widespread. 40 million have no teeth. Bridges restore function. Dental bridge, a fixed prosthesis replacing a gap, restoring chewing, speech, aesthetics, and occlusal stability. Bridge components, supports, meaning, abutment and retainer, plus pontic and connector. Next, why replacement matters. Missing teeth cause shifting, chewing decline, bone loss, smile and speech problems. Bridges replace gaps. Bridges restore function quickly. Implants take longer. RPDs are removable and cheaper. Next, common scenario. Use patterns, not prescriptions. Scenarios often map to these choices. Next, timeline expectations coming up. Timelines vary. Resin bonded 1 to 2 visits, bridges 1 to 3 weeks, partial dentures 2 to 6 weeks, implants 3 to 9 months. Here's our roadmap. Essential bridge topics ahead. Next up, we begin with bridge types now. These are the 4 dental bridge types: traditional, cantilever, resin bonded Maryland, implant supported. Next, traditional bridges link 2 abutments with a rigid pontic, ideal for short spans. Next, cantilever. Cantilever bridges contrast traditional. Choose low-load anterior premolar cases. Posterior risks higher. Next, resin-bonded Maryland bridges. Maryland bridges, conservative option for single anterior. Survival 80 to 88%. Next, implant-supported bridges. Implant-supported bridges place restorations on implants, offering survival and bone preservation. Next, pontic design choices. Pontics, modified ridge lap for aesthetic zones. Ovate sculpts tissue, sanitary posterior mandibular, conical narrow ridges. Common bridge materials: PFM, zirconia, lithium disilicate, and full cast metal. Strength versus aesthetics. Next, lithium disilicate emphasizes aesthetics. Zirconia very strong. PFM chips. Full metal lacks aesthetics. Next, bar chart. Flexural strength varies widely. Lithium disilicate lowest, gold and PFM mid, zirconia highest. Next, connector. Set connector size by site and material. Longer spans flex. Choose rigid or non-rigid wisely. Ante's law guided abutments historically. Today we balance support, root form, loads, splinting, occlusion. Next, assess occlusal forces, avoid cantilevers, load axially, manage bruxism. Next, pontic tissue contact and hygiene implication. Maintain gentle, convex tissue contact. Avoid overpressure. Ovate needs shaping. Hygienic pontics simplify daily cleaning. Digital scanning, CAD, TAM, milled ceramics, wax-ups, and printed provisionals streamline candidacy assessment. Next, bridge indication. Choose conventional bridges with favorable abutments, especially when implants aren't suitable. Contraindications and cautions next. Watch for weak abutments, disease risk, and long spans. Next, span length and abutment selection. Prefer short spans. Choose long, multi-rooted abutments. Target 1.1 minimum. Consider implants for long span. We assess periodontal prognosis, caries, drivers, and margins, systemic modifiers like diabetes, smoking. Next, younger patient. Defer implants until growth completes. Bridges/RPDs. Adolescents, resin bonded. Older, conventional. Next, smile zone aesthetics and soft tissue. Align, midline, incisal edge, smile line. Preserve papillae. Manage ridge volume with ovate pontics and pink ceramics grafting. Optimize for natural shade, translucency, texture. Here's the clinical workflow at a glance. Next, we dive into detailed assessment and planning. Before preparation, complete diagnostics, plan aesthetics and occlusion, and verify abutment suitability and biological stability. Sound prep, accurate reductions, 6-degree taper, rounded internal angles, ferrule. Next, impressions and temporization ahead. We capture margins with impressions or scans, provisionalize to protect, maintain occlusion, test. Next, lab. Lab designs framework, verifies fit, builds aesthetics, performs quality checks. Next, clinical try-in and adjustment. Before final placement, confirm fit, contacts, occlusion, and aesthetics. Next, review cementation options and protocol. For fixation, pick RMGI for metal, resin for bonding, isolate well. Next, immediate post-cementation checks. Recheck occlusion, clean underpontic access, remove excess cement, take baseline radiograph, then review outcomes. Evidence. Here's a snapshot of bridge survival over time. Next, we'll cover common complications and frequency. Common issues: caries, debonding, chipping, endodontics minority, fractures rare. Risk rises with poor hygiene, bruxism. Underpontic cleaning matters. Choose hygienic designs. Maintenance reduces complications. Next, bone and adjacent teeth alignment. Bridges stabilize adjacent teeth and occlusion. Ridge beneath the pontic remodels. Contacts reduce impaction, drift. Typical U.S. costs shown. Timelines vary. Many insurers cover half, 5 to 7 year replacement limits. Comparisons next. Bridge, implant, and RPD differ by invasiveness, timeline, bone, longevity, and maintenance. Next, bridge candidates. Common choices: single tooth gaps, strong abutments, neighboring crowns needed, implant limits, resin-bonded temporization. Next, longevity. Longevity depends on abutment health, clean margins, short spans, controlled forces, connectors, hygiene, and recalls. Bridges don't always harm teeth. They don't stop bone loss. Resin-bonded bridges last. Maintenance next. Quick recap: clean underpontics, prefer cleanable designs, protect bruxers to reduce wear. Numbers next. At 10 years, survival is 80 to 90%. Timeline averages 1 to 3 weeks. 5 essentials: abutment, retainer, pontic, connector, FPD. Memorize them now to power the final synthesis. A dental bridge is a fixed prosthesis joining pontic to abutments, restoring function and aesthetic.